Okay, good morning everybody. We will get started. This looks to be a very interesting session in a very important topic, and we've got a great lineup of speakers this morning. We've got plenty of time in the program for questions and for discussion, and I hope we're going to make good use of it. We're going to start first with Professor Helms from Strasbourg. He's going to give us an overview, I think. Thank you, Professor.
Thank you very much. Dear colleagues, it's a pleasure to be here. I first would like to thank the organizing committee for having invited me. I'm working in medical ICU in Strasbourg University Hospital. I don't have any conflict of interest. So it's now well known that COVID-19 is associated with a coagulopathy. From a clinical point of view, there is a hypercoagulability and a prothrombotic state, especially in the most severe patients. These patients indeed have an increased risk of deep vein thrombosis, pulmonary embolism, or clotting of external devices like ECMO and renal replacement therapy. And this is especially concerning as this thrombosis occurs despite prophylactic or therapeutic anticoagulation. The mechanism underlying this hypercoagulability still remains unclear. But the infection by the virus will lead to a hyperinflammatory state that will lead to endothelial activation and subsequent dysfunction, itself leading to the coagulopathy. Indeed, when the virus enters the cell through ACE2 receptor, it will lead to the activation of innate immunity with a very important inflammatory response and the release of pro-inflammatory cytokines like IL-2 receptor, TNF-alpha, IL-6. And these pro-inflammatory cytokines will first increase the vascular permeability, but will also contribute to the activation of the complement. It will also activate the endothelial cells, and the endothelium become pro-adhesive and procoagulant due to the activation of coagulation. And this will lead to macro and micro thrombosis in these patients. But besides the endothelial dysfunction, hypoxemia in the pulmonary capillaries will also play a major role in the pathophysiology of COVID-associated coagulopathy, because hypoxemia will favor vasoconstriction of pulmonary capillaries, which will reduce blood flow and promote vascular occlusion. Also, it can induce hypoxia-inducible factors that may inhibit or induce many genes, including tissue factor and PI1. Finally, the important lung inflammation due to the virus infection may lead to impaired fibrinolysis in the lung, leading to accumulation of fibrin in the alveolar spaces. And all these mechanisms explain why these patients develop a lot of thrombotic pulmonary events. From a biological point of view, COVID-associated coagulopathy is mainly characterized by elevated D-dimers and fibrinogen, while platelet, APTT, and prothrombin time remain within normal ranges in most of the patients. We have also described very high levels of factors 8 and Willebrand, traducing the very important endothelial activation in these patients. But all these results are not consistent with disseminated intravascular coagulation. First, because we do not have any consumption of coagulation factors or platelets. Then, we also have a very important inflammatory state in these patients. And all of these results explain why the IC scores are normal in almost all patients on ICU admission. These patients have no disseminated intravascular coagulation, although they already have a procoagulant state at admission. If you look at these 10 patients, which are patients with ARDS due to COVID, these patients have been followed during 7 days. And you can see that almost all routine coagulation markers remain within normal ranges during all ICU stay, except fibrinogen and D-dimers, which are probably elevated due to thrombotic events. And I will try to show you why. First, D-dimer is probably the most promising test to detect a procoagulant state because it measures fibrin breakdown and ongoing fibrinolysis. Up to now, you all knew that the use of D-dimer has been restricted to exclusion of thrombosis because of poor specificity and better sensibility, making false positive results quite likely. But this is non-COVID application. And in fact, there are several studies and several teams that have tried to find a D-dimer cutoff to screen for pulmonary embolism or deep vein thrombosis. And as an example, this is a French cohort with 162 patients who underwent a CTPA, and 44 pulmonary embolism were detected on this CTPA. And as you can see, a D-dimer cutoff above this one is associated with a 83-84% sensitivity and specificity respectively. And it is also associated with a 17-fold increase of pulmonary embolism in these patients. But as you can see here, the kinetics of D-dimers is probably even more interesting than one measure of D-dimer, because in this study you can see that patients who have developed thrombotic event have higher D-dimer during all their stay in black, while in white patients have lower D-dimer and they have no thrombotic event. And several teams have suggested that the kinetics of D-dimers could help in guiding anticoagulant treatment, because in fact D-dimer is decreasing when the patient is improving, and when D-dimers are increasing, usually patient has a thrombosis. But as routine coagulation tests like specificity to make the diagnosis of COVID-associated coagulopathy, viscoelastometric testings have been suggested to be good global tests to assess coagulation and fibrinolysis in whole blood. And very early in the first wave, Moro Panigada and colleagues have shown that COVID-19 patients have a hypercoagulable state associated with a very severe inflammatory state. Here is a typical TEG tracing with upper and lower line featuring a COVID patient and a healthy subject. And Spiezza and collaborators have shown quite similar results with Rotem, and all these results are due to the fact that fibrinogen levels are very increased, and we also have excessive fibrin polymerization, which also explain why we have high D-dimer levels in these patients. Here is a very interesting systematic review that has been recently published, and you can see that they have compared 44 studies with 25 studies using Rotem, 15 studies using TEG, and as you can see, most of the Rotem studies showed hypercoagulable profile and impaired or absent fibrinolysis. But what is really interesting is that only 4 studies of the 25 have displayed heptamer results, although almost all patients received heparin. The second point that we should bear in mind is that only 6 of the 25 studies have looked for a potential association with thrombotic events. We have nearly the same results with TEG. So we have 15 studies. TEG studies mostly showed a prothrombotic profile with impaired or absent fibrinolysis. But whether the association between hypercoagulable pattern and thrombotic event is real is still a matter of debate, because as you can see, only 7 of the 15 studies have looked for an association. These studies included 243 patients, and these studies showed no association between the prothrombotic profile and the occurrence of thrombotic event. Only one study, including 21 patients, shows that an increased maximal amplitude had a sensitivity of 100% and a negative predictive value of 100%, but confidence intervals are not provided. The second point is the ability of viscoelastometric tests to assess impaired fibrinolysis. Some of the studies I have just described have added TPA to their test, and these studies have showed that there was a decreased clot lysis, which was more important in patients without thrombosis compared to with thrombosis, in red, compared to patients without thrombosis in black. However, the addition of TPA in this test is still not clinically validated. The second point is that viscoelastometric tests cannot detect fibrinolysis unless TPA is over pi1, which can only occur in hemorrhagic situations like with hyperfibrinolysis, like peripartum hemorrhage or trauma. Without going the limits of my presentation, I just would like to insist on a few points before my conclusion. The first one is that for ICU patients, we have to find a good balance between thrombotic risk, because these patients are all at higher risk of thrombotic event, whether COVID or not, but they are also at higher risk of hemorrhagic situation. The second point is that some of the treatments that we will give to our patients for COVID will affect coagulation activation. And here is the example of corticosteroid. As you can see, corticosteroid will decrease inflammation. This will decrease the activation of endothelium. It will also decrease coagulopathy, and of course, it will decrease thrombotic events. So, taking all these points into consideration, my main concern about the studies that are currently being published is about the comparability of the patients. Because between March 2020 and now, the treatment of COVID patients has considerably evolved. During the first wave, we used no corticosteroid. Patients were all intubated, and we used only prophylactic anticoagulation. Now, all our patients receive corticosteroids, most of them receive immunomodulator treatments, few patients are intubated, and we mostly use reinforced or therapeutic anticoagulation levels. And all these points probably explain why we have fewer thrombotic events now than we had during the first wave. So, as a conclusion, COVID-19 is a prothrombotic state. It is associated with a coagulopathy, but this coagulopathy is not a disseminated intravascular coagulation. Whether the ability of VATE to discriminate between high and low risk of thrombotic event is real is still a matter of debate. And I would suggest that D-dimers are a simple and strong test to detect a procoagulant state and maybe even to adapt anticoagulation levels. Thank you for your attention.
Thank you very much. Any questions for Professor Helms? So I have one to start. The mechanisms of coagulopathy that you proposed are quite generic to all inflammatory states, and and even to generalized sepsis state. So do we know the specific features of the SARS virus that makes it, or its response that makes it so different compared to other viral diseases?
I'm not sure we have really specificity from this coagulation activation, because as you said it, it's quite generic, and in fact, patients with ARDS and flu, for example, probably have the same type of coagulation activation, because we will have the same mechanism of hypoxemia in the pulmonary capillaries and so on. But maybe the difference between COVID-19 and sepsis coagulopathy is the intensity of the inflammatory response. This is probably one of the first mechanism. However, why we do not have such a consumption of coagulation factors and of platelets is still unclear, I think, because we probably have a platelet dysfunction, but I have not talked about it. I thought it would be just in the further talk.
And my other question was, a lot of the features like high fibrinogen, high D-dimers are also markers of a post-rebound state where you've had a very acute early activation of coagulation that then leads to rebound phenomena. And I was wondering whether the early phase of the coagulopathy occurs outside of ICU, even outside of hospital in the first few days, and whether that has been studied or whether there's any possibility that the actual drivers occur before these studies are being done.
Probably yes, because patients probably have a hypercoagulable state far before they are admitted to ICU. I agree.
There have been studies really showing the virus in the endothelial cells.
Yes.
And nevertheless, functional research on the capillary function, on the microcirculatory function, has shown that the systemic capillaries work very well, which is, of course, in line with the absence of a DIC as such. So what do you think is the role of this endotheliitis?
It's difficult to answer because as far as the coagulopathy is concerned, I'm not sure it really plays a role for the triggering or for the initiation or the propagation of coagulation activation. I don't have any opinion about it. In fact, I'm not sure. I don't know. I don't know what to answer.
Yeah, I'm not sure anyone does. Okay, thank you very much, Professor Helms. Thank you. Should we move on?
Okay, so we will continue with Professor Hendrik Endeman from Rotterdam in the Netherlands, and we will have the pleasure to hear from him on the risks of thromboembolism.
Yes, thanks a lot. Thanks the organization for giving me the opportunity to present here. I have to justify a small thing. I'm not a professor, but I'm from Rotterdam, yes, that's right. And I'm going to tell you something about risk of thrombosis in COVID-19 disease. And this might be one of my shortest talks ever, because the main risk of thrombosis in COVID-19 is having COVID-19. But again, I think that's a little bit too short. I have nothing to disclose on this topic, but I have an interest and experience. I'm actually an intensivist with my main area of interest in mechanical ventilation, or probably many of you know this piece of scientific work our group did together with the Leiden group. And if you review literature on thrombosis in COVID, then many times this piece of work is cited as the first report of a majority of the patients with COVID having thrombosis. And I hope the chairs give me the possibility, because it's a little bit outside my subject, I want to justify and clarify this. Because to do this, I have to take you to my hospital. I work in the Erasmus MC. It's normally, for Dutch circumstance, quite big ICU. We have like 50 beds. We have a group of intensivists and junior staff and fellows, which are people who are want to be intensivists in the future. And during COVID, actually everything doubled, apart of the intensivists and the junior staff. So we knew we had to, would be confronted, like you all, with a large group of patients, not having intensivists taking care of them, and not having enough junior staff with ICU experience. And what we did is we built a COVID expert team, and this COVID expert team built a couple of protocols, actually to help these non-intensive care doctors to be aware of complications of COVID. And which were these complications we defined? We looked in the Chinese and Italian literature, but not only the scientific literature, we just screened the internet. We looked at Google, we looked at the Italian intensivist groups talking with each other, and then we defined all the common denominators of complications of of COVID, ventilator-associated pneumonia, bloodstream infections, cytokine release syndrome, or secondary HLA, but also thrombosis. At the same time, we had a real-time data warehouse constantly checking our protocols whether they still fit. And one of the other strong things of our clinic is that we have an advanced respiratory care team. It's a group of nurses and technicians who perform EIT, ultrasound of the lung, transpulmonary pressures in all the patients with severe RDS. And what happened actually is that these protocols were running at the moment the first COVID patients were entering our ICU, and we saw, as we all saw, high levels of D-dimers, but also large gaps between arterial and end-tidal CO2, which was a part of the protocol. And what we discovered is that our normal mechanical ventilation protocol, which is based on the high PEEP low FVO2 table justified by our respiratory care team, it did not always work well. We had perfect levels of PEEP, the EIT was beautiful, transpulmonary pressures were high enough, but we still had oxygenation problems. So our data warehouse started alarming from, okay, there's something wrong with the protocol, and we added CT angio, first at admission, and later on also during the ICU stay. And that was actually the moment we discovered that thrombosis was such a large problem in ICU patients. So it's the first scientific report this is published that this is a problem in a large group of ICU patients, but actually reports from China and Italy which already made us alarm to build this protocol. So yes, it's one of the first publications. It did make it possible for us to change our prophylactic antithrombotic strategy, although you can discuss if that makes sense, but that is how the story is when you tell it in the right way. Okay, so these are the figures we published. The first figure we had a thrombotic event in 40% of the patients. This is not as much as we see now, but actually it was quite simple. Our hospital had this protocol, so we had a lot of patients, we had a lot of CT angio. For us it was quite easy to diagnose pulmonary embolism or pulmonary thrombosis. Later on, this incidence increased in the second publication we did, but actually the only thing which was changed between these two studies is that the Leiden group also started to adopt our protocols. The true thing is that this thrombosis reported in COVID ARDS. And as we all know, these kind of figures, and there were similar figures were nicely shown by the former speaker. You have different, within a course of COVID, you start with a viral phase. I actually feel, my feeling is that there is also a procoagulant state at that moment already, but it's going over in a host inflammatory response phase, and then we get really in problems, starting with more and more patients needing oxygen, needing mechanical ventilation, ending in your ICU, and then we did diagnose the thromboembolism. I think this is really a nice overview by the group of Kelvy, showing the differences between COVID ARDS, normal ARDS, and sepsis with Dick. And especially this part of the picture is nice. Although I feel that this is a part of the story, that in ICU patients there is a transition from the phenomena which are quite restricted to COVID-related ARDS to normal ARDS. But the beginning is with, as told by the former speaker, invasion of at least pneumocytes type 2. This invasion of viruses in the endothelium, sometimes you find it, but also many times it's not found within the endothelium. So I'm not completely sure if there is viral invasion of the endothelium of the pulmonary vasculature. But anyhow, it results in an inflammatory response of the endothelium, and this endothelitis results in activation of coagulation, thrombosis, capillary leakage, venous congestion. And this is also reflected, as told by the former speaker, of these high D-dimers. So if you talk about the risk of thrombosis in COVID-related ARDS, actually the only real risk is that you look at immunomicrothrombosis as a hallmark of COVID-related ARDS itself. So if you have to want to talk about risk, it's actually talking about staging and severity of this inflammatory response. It might be more interesting whether there are patients, for example, because they use a specific home medication, which are protected against this thrombosis. And if you screen the literature on this last subject, you don't find very much. There are some studies about aspirin, they're all retrospective, of course, but results are limited. And till now, it's mainly focused on anticoagulants, and probably you should also focus on anti-inflammatory drugs, and might be even NSAIDs. Okay, but then get to the real risk of thrombosis. If you look outside immunothrombosis and you look at the classical risk of thrombotic and embolic events, there are some meta-analyses. There are small journals, but there are two which make sense. And one is that diabetes is one of give an additive risk of pulmonary embolism in a COVID-related ARDS. And the other is BMI. And actually, I'm not completely sure whether this is an extra risk within patients with COVID with ARDS and diabetes and or a higher BMI leading to thromboembolism, or whether these are, because these are the patients who are at risk for COVID-related ARDS in the ICU, it's more or less that these patients anyhow have a higher risk of getting to the ICU, making it possible to diagnose thromboembolism. But anyhow, the meta-analyses say that above the immunothrombosis and inflammation, diabetes and BMI might give an extra risk. This is a funny review. In this review, and you cannot read anything about it, and that's okay, because what they did, they screened on all the classical risks for pulmonary thrombotic events, and actually none of these risks is present in COVID-related ARDS and thromboembolism. And they state that diabetes might even be protective. I don't understand this. There's a story about metformin, but I don't get the pathophysiologic phenomenon behind it. So no, there are no additive risks as we know from literature outside COVID-related ARDS and thromboembolism. So this makes it quite difficult because the pre-existent risks for thrombosis in COVID ARDS seems to be not the classical risks at least, maybe diabetes, maybe BMI. But till so far we don't know nothing about the effect of home medication, and we know that this is immunothrombosis, but I think it's even get worse, because also in our studies we used CT scanning as the endpoint to diagnose pulmonary thrombosis. But you probably know these kind of pictures, that you have CT scans which are, and you use software to look at the perfusion defects beside perfusing defects in the main arteries, and you can do the same with PET-CT, and then you can nicely see it in this picture, that outside the areas which are affected by COVID, there are perfusion defects also on other areas. There are many reports on this now. So even if you don't see pulmonary embolism on your CT scan, there might be large perfusion defects anyway, and that really fits the diagnosis that this is extended microthrombosis, and not only thrombosis of the pulmonary main arteries. And I think actually what you said a few minutes before, we're looking at pulmonary thrombosis, and the anticoagulant state of the rest of the system might be limited, and indeed this is reflected by the normal microcirculation as we published somewhere else. Then the dimer. Of course, the dimer itself can never be a risk factor. It can only be a marker of inflammation and immunothrombosis. And this is nicely shown by the former speaker, and even goes a little bit further, and I'm not completely aware of this study will make a big difference, but what they did is they used dimer at admission in combination with TEC to identify patients needing more or less prophylactic anticoagulants. And I think it makes sense because it goes from one size to one size fits one. And indeed, if you look at the primary and secondary outcome in the study, using this cutoff of 1500, which is probably quite close to the cutoffs which were shown in the studies shown before, that you have a decreased incidence of thrombosis, and at the same time you have a decreased incidence of the adverse events of using a high dose of prophylactic anticoagulation. But anyhow, again, in this study, they don't have a routine protocol for identifying thrombosis by CT angio, and they don't look at the microthrombosis by using software-enhanced CT scans or perfusion defects picked up by PET scanning. It might be even worse than this. And of course, there's a link of D-dimer risk and arterial and venous thrombosis and pulmonary embolism. Also perfusing defects on CT scan, it's shown in many studies. I won't go much further than that in case of the time. But yes, D-dimer is a good risk marker of thrombosis, or shown thrombosis. But the same counts for CRP, procalcitonin, interleukin-6, and even LDH. So D-dimer among other variables, there are many algorithms in literature you probably are aware of. I think if you look at literature on algorithms in the first aid department, there are many algorithms using D-dimer to identify patients at risk for thrombosis. None of them have a really high sensitivity and specificity. And it might be that the best anticoagulant is not a prophylactic anticoagulant, but is, as said by the former speaker, it is in the corner of the immunomodulatory drugs like corticosteroids. So in conclusion, what's the main risk of thrombosis in COVID-19? If you identify risk of thrombosis, reported thrombosis or thrombosis shown on CT scan, or that you look at thrombosis, immunothrombosis, in all cases the main risk is, in my opinion, it's only inflammation. And that's the story I would like to share with you.
Thank you for this excellent overview. I would first ask the audience if there are any questions. So maybe I will start with one. So what many studies emphasize, or have emphasized early on, as you have also shown, is the big difference in pathomechanisms in the lungs versus the systemic organs, with namely this absence of the cytokine storm that we may have expected of this novel disease. And one of the most influential interventions in therapeutics that we have done was arguably the change in heparization protocols, which you have also very nicely shown.
Yeah.
So do you think this has made a difference in the pulmonary capillaries, in the pulmonary perfusion?
Yeah. Oh, yeah. That's we have nowadays we have studies about the effect on outcome of adding or changing your prophylactic anticoagulant protocol, and there's much discussion how much sense this makes. I actually agree what you said, your question in the former speaker. I think the main differences with regard to thromboembolism and activation of the capillary membrane was adding these corticosteroids. And we also published a study, but it's very small. We were quite early with adapting high-dose steroids. And actually, if you look at, if you use high dose, I don't want to say that this is the golden grail, but if you add high dose steroids quite early in the course of disease, you see, of course, an immediate drop in interleukin-6, but also in your D-dimer. But we had significantly less in our single center experience thromboembolism in the upcoming course after adding this. So I feel. I'm unsure whether this change in anticoagulant strategy made a big difference. It's actually only the anti-inflammatory effects of other interventions make the big difference. And I agree with you, but we looked a lot at a viral invasion of the renal or the liver or the heart, and you have these publications, but I think there are much more publications which are not published, showing that they did not find this virus. And I agree with you, we had this critical care publication on the microcirculation, and actually, when we did this research, we expected clotting, but there was nothing even in the neighborhood of clotting. It was excellent microcirculation. And so the true answer, I doubt whether it's the anticoagulants which had any effect. It remains by that.
That's a very good point, and it was really surprising to see how well or how little influence this virus that was present in the systemic organs, obviously, really made on their function.
Exactly.
So until the point where the patient descends into multi-organ failure, of course, then it's a different situation. The systemic organs seem to be quite unaffected, but there is still this systemic risk, as you said, of thromboembolism.
Exactly. And because we also had this protocol of looking at cytokine release syndrome, but actually there was really a small group which had this classical secondary HLA secondary release syndrome, and IL-6 was it was not low, but it was quite low compared to other disease states. Yeah, I agree. Okay.
Can I ask you about your data warehouse that picked this up so early? How does that work? Is that a number of small people sitting in an office watching what you do, or is it a machine learning?
Yeah, it's just what we did is in the beginning. We started with we just did a dump of all our data, the data which you normally gather in ICU. Together with these data, we added some kind of extra biomarkers to screen for these COVID-related complications. And we get a weekly update on what was happening with all these data, what was happening with outcome. And so each Friday, in the beginning, each Friday was a little bit strange because data were going all directions. But after a few weeks, we gathered enough patients to see patterns. And then we changed our protocols. And indeed, I think it was about after 3 or 4 weeks that we saw that there was we saw within the protocol developed to screen for pulmonary, we called it pulmonary embolism then, but actually it would be this pulmonary thrombosis. Then there were discrepancies between our ventilatory protocols saying, okay, you're doing really fine, and this protocol telling that there might be pulmonary embolism. And that was it. Indeed, it was data mining, giving an update each week by the data manager, which is also an intensivist.
But that process is something that you do every day or every week routinely, or it was something that you specially...
No, one of our research lines is on big data, so it was already present. We did not use it as we did during COVID, but during COVID it was interesting because there was a large homogeneous group of patients that made it possible to do it like this. We still do it, but as our normal ICU population is far more heterogeneous, it's not so easy to correct your protocols as it was by COVID. Yeah.
And just in a similar vein, how much do you think we've picked up these thrombotic events in COVID because there are so many patients? And do you think we've been missing it in other viral pneumonias or other pneumonias just because it's relatively rare and we don't see them as a homogeneous group? Or do you think this is specific to COVID?
Yeah, that's of course an extremely good question because we never built these kinds of protocols or data warehouse corrections for normal pneumonia or ARDS. Actually, this sounds stupid. We still use these protocols of screening, but the nurses like them so much they use them in all patients. So now we are, without any purpose, building a kind of database whether there is indeed a same pattern within non-COVID ARDS. But these results are true preliminary. I think it's quite specific and maybe self-pathogenetic. for COVID-related ARDS. But actually, we don't know. I think we miss a lot of pulmonary embolism also in normal ARDS, but that's only assumption.
Thank you very much for this very good discussion. So we will stay in the Netherlands and move to Amsterdam, and we're happy to welcome Tom van der Pol, who will talk about platelet activation.
Good morning, everybody. Topic of my talk is closely aligned to the two previous speakers. It's about platelet activation in COVID-19. The previous speakers already alluded to the fact that COVID-19 is associated with activation of the coagulation system, and this is illustrated on this slide by decreasing fibrinogen levels, in particular in the non-surviving patients with COVID-19, and also elevated levels of D-dimer, although the first speaker already alluded to the fact that D-dimer is not just a coagulation marker. Severe COVID-19 is also associated with a decline in platelet count, so these are the non-surviving patients, showing that it can be associated with thrombocytopenia. These changes, and that was the topic of the previous talk, have been associated in the early days of the pandemic with thromboembolic and bleeding events. So this is a paper coming from Blood, and you see the independent associations of elevated D-dimer levels with the venous thromboembolism, elevated D-dimer levels, and also with bleeding events. So these are the major bleeding events, elevated D-dimer levels, so independent risk factors. But also platelet counts are associated with these events. So high platelet counts are associated with venous thromboembolism, and low platelet counts are associated, not surprisingly, with bleeding. So there is a clinical relevance to the changes in coagulation, and this talks about platelets. So there's also a clinical relevance, seem to be, with changing platelet counts. Well, it's not just changing platelet counts in COVID-19. There's abundant evidence now that COVID-19 is associated with activation of platelets, and I'm going to show you a few slides. So this first slide comes from our own group done by Valentine Leopold from France, and she looked in the first wave of the pandemic in the Netherlands, so no associated concurrent treatments around there, that platelet activation is prevalent, highly prevalent in COVID-19. So these are healthy controls that are matched for comorbidities. So these are also elderly people, but without acute infection. And enhanced P-selectin expression on circulating platelets. And what these activated platelets also do, they form complexes with other blood cells, neutrophils, also monocytes. I'm going to talk about this a little bit later. But this is neutrophil platelet complexes, and what is interesting that once platelets complex with neutrophils, the neutrophils become more activated. So this is a readout by flow cytometry, CD11B expression. Enhanced CD11B expression indicates enhanced neutrophil activation, and the neutrophils that are complexed with platelets show enhanced activation, indicating that platelets contributes to neutrophil activation in COVID-19. Now this is a classic readout of platelet activation, that's platelet aggregation, which is clearly also enhanced in patients with COVID-19. The pinkish bars are non-ICU patients, the bluish dots, sorry, the two bluish dots are ICU patients, and the pinkish dots are non-ICU patients. And here you see all these different stimuli that have been used to induce platelet aggregation, and clearly there's enhanced aggregation controls versus patients, and this is true for all of these stimuli. Another sign of platelet activation is that they can degranulate, and this was a nice study published also last year, comparing platelet content of certain degranulation products and plasma concentrations of these degranulation products. They measured platelet factor 4, which is lower in its contents in platelets when compared to healthy controls in COVID-19. And when you look at plasma levels, the plasma levels of platelet factor 4 are highly elevated in COVID-19, indicating that these platelets release platelet factor 4, and the same is true for serotonin, also reduced platelet content and elevated plasma levels. So another sign of platelet activation in COVID-19. Now, another indication of platelet activation is that they can release microvesicles, and this is a diagram showing this. So platelet activation results in the release of these microvesicles, and you can actually detect them in the circulation or in other body fluids because these microvesicles keep expressing the receptor of, that identifies platelets, and CD41 has been used extensively to analyze platelets by flow cytometry, but also to analyze the microvesicles they release. And this study shows that platelet microvesicles are increased in the circulation of patients with COVID-19. So these are healthy controls, and these are two groups of COVID-19 with increasing severity, and clearly there's enhanced circulating levels of CD41 positive microvesicles, indicating microvesicles derived from platelets. And these microvesicles from platelets express phosphatidylserine, and that's important in the context of coagulation because phosphatidylserine provides a surface at which coagulation factors can assemble, and thereby these surfaces propagate coagulation activation. So this is one mechanism by which platelet activation induces also coagulation activation. Let's then look at the main driver of coagulation activation, which is tissue factor. And tissue factor is usually not expressed on cells that are exposed to the circulation. Tissue factor can complex with factor 7, and then this complex activates factor 10, thrombin, and fibrinogen. So this is a major driver of coagulation activation. And in stimulated conditions, including COVID-19, tissue factor becomes expressed on circulating cells. And this is illustrated here. So these are monocytes in the circulation, and there's enhanced tissue factor expression in COVID-19. Now what's interesting to see is that platelets form complexes with monocytes, just like that they form complexes with neutrophils. I showed it in one of my previous slides. But what's more interesting to see is that once platelets complex with monocytes, these monocytes enhance their tissue factor expression. And this is illustrated by the difference here between these two groups. So once platelets attach to neutrophils, the neutrophils become more activated, and once platelets attach to monocytes, the monocytes express more tissue factor and thereby contribute more to coagulation. So platelets play a role in interacting with other blood cells, in activating them, and thereby also regulate the immune response and the procoagulant response to COVID-19. Then with regards to the mechanisms by which platelets become activated in COVID-19, and this is a study that was just released, a very interesting study, and they looked at the effect of plasma from COVID-19 patients. So the question here was, does plasma of COVID-19 patients contain factors that can activate platelets? And the short answer is yes, it does contain factors. So this is healthy plasma. And this is plasma from COVID-19 patients. And the first parameter by flow cytometry is expression of P-selectin on platelets. So on these healthy platelets, this is a purely in vitro experiment. So when you co-incubate healthy platelets with COVID-19 plasma, they start to express P-selectin, indicating enhanced activation. But they also express tissue factor, and this is illustrated here. What they also do then is they start to release microvesicles, so platelets start to release microvesicles that express tissue factor. So apparently plasma from COVID-19 activates platelets and also enhances their procoagulant capacity. These authors then asked the question, well, which factors may contribute to this effect of COVID-19 plasma, and they carefully read the literature, and these are two papers that came out several months ago showing that several anti-interleukin-6 strategy confer a beneficial effect in patients with COVID-19. So this is both tocilizumab and an interleukin-1 receptor antagonist from another company. So they asked the question, does IL-6 play a role in the phenomenon induced by platelets, by COVID-19 plasma? And the answer is yes, it does. So let's first look at the right part of the slide. This is plasma from COVID-19 patients. This activates platelets when you look versus healthy control plasma. And then when you add anti-IL-6 to the plasma, there's this here, the tocilizumab, the activation of the platelets decreases. The opposite experiment is adding interleukin-6 to normal plasma. Interleukin-6 by itself does not activate platelets, but when you add a platelet agonist like ADP, platelet activation becomes apparent, and then adding IL-6 to this system is a synergistic effect. So IL-6 enhances platelet activation induced by ADP, and overall this shows the role of endogenous IL-6 in the capacity of COVID-19 plasma to activate platelets. And this is not only true for activation, so this is the procoagulant capacity of platelets, that is the release of microvesicles that express tissue factor. And let's first look at the anti-IL-6 effect again. So plasma from COVID-19 patients induces this release of tissue factor positive microvesicles from platelets, and this can be prevented by adding tocilizumab anti-IL-6 to the system, clearly indicating that IL-6 plays a role, and also IL-6 synergistically enhances the ADP-induced release of tissue factor positive microvesicles from platelets. Okay, this is a study done by Alex Schuurman. He's in the audience together with Valentin Leopold, asking the question, do lipids in platelets contribute to platelet activation? And the first question actually was, are lipid profiles changed in platelets from COVID-19 patients? So what Alex did here, he compared the lipidome of platelets from patients with COVID-19 and matched control, so also elderly persons with comorbidities and similar co-medications. And he looked at over 1,600 lipids by HPLC in lipid lysates. And what he found is that the majority of the lipid content of platelets did not differ between patients and controls. So 75% of everything, of all the lipids was normal, was unchanged, the lower part. And then 20% was approximately downregulated. So the majority of lipids that he found in the platelet lysates was lower in patients with COVID-19. And actually when he looked at the top 15 differentially abundant lipids, all were downregulated and they were belonging to phospholipid and lysophospholipid classes. Now this is just observational, and it was striking to see that there were certain lipid classes that were elevated in patients with COVID-19 platelets, and these are related to LPG and BMP lipids. And this is shown on this slide here, so these are different lipids belonging to these classes, and these are higher, so the COVID-19 patients are in red than in controls. We'd also seen that patients, platelets from patients had enhanced P-selectin expression in basal state, but also upon stimulation of the thrombin receptor, which is PAR1, elevated in COVID-19. And what was interesting to see is that there was a strong correlation between these elevated LPG and BMP levels with the platelet responsiveness to PAR1 stimulation. So this is a first hint that lipids in platelets may contribute to the enhanced platelet activation in COVID-19, but obviously this requires further research. Now then you might ask the question, there's so much evidence that platelets are activated in COVID-19, let's block them. Well, it's not you don't have to be a neurosurgeon to come up with this hypothesis. So this has been trialed, and the data are not out yet. So I looked on the internet and I found several press releases of large trials that looked at antiplatelet drugs in patients with COVID-19. This is coming from the recovery trial. You may all know this. It's a British consortium, and they trialed aspirin. And this is what I found on their website. This is a press release. There's no data found on internet or on the unpublished data website, the metrics website, but you can find the data here. So they tested aspirin, and it's a fairly large group, close to 15,000 people, and the primary endpoint was 28-day mortality, was not different between groups, and also in the non-critically ill patients, those that were non-invasive mechanical ventilation, the progression to invasive mechanical ventilation or death was not altered by aspirin. There was a slightly shorter duration, and this intrigued me a little bit, a higher proportion of discharge from hospital alive within 28 days. In the aspirin group, I'm not totally sure how you connect this with this primary endpoint, but anyways, we'll be awaiting the full article. The conclusion is that aspirin is not beneficial. It is associated with a slightly enhanced risk for major bleeding, but also with fewer thromboembolic events. There's one more big trial, that's the REMAP-CAP. You know this. This has been widely publicized in major journals with different interventions. It's an adaptive trial design, and part of their trial was also aspirin and P2Y12 inhibitors like clopidogrel. And basically what they found, there was no effect of these two platelet antagonists. So they behaved similarly in the trial. It was close to 1,500 critically ill patients, and the conclusion was written on the website of UMC Utrecht, which is a major player in REMAP-CAP, that basically there was no effect of either aspirin or P2Y12 inhibitors in critically ill patients with COVID-19. So in conclusion, what I've showed you is that there's abundant evidence that COVID-19 is associated with exaggerated platelet activation, that activated platelets have several mechanisms by which they contribute to coagulation activation in COVID-19. And one of the mechanisms that is involved is increased tissue factor expression. I've also showed you that there's evidence that IL-6 is involved in enhanced platelet activation in COVID-19 and also in their capacity to mount procoagulant activity. And finally, somewhat disappointing to conclude with, there's two major trials out there that have not been published yet that indicate that antiplatelet therapy does not impact mortality in COVID-19. Thank you very much for your attention.
Thank you very much for this excellent overview, also bridging the basic research and the clinical insights that we have previewed. Are there any questions from the audience on this?
Yeah, Tom, many thanks for the excellent talk. You talked about IL-6 as a platelet activator, but as IL-6 is one of the cytokines which can activate platelet, and we see a lot of cytokine elevation within COVID, do you feel it's solely IL-6 which does this, or is it only IL-6 which has been examined?
Well, the latter is true. So IL-6 was a target that seems logical in terms of that the tocilizumab interventions were beneficial in terms of outcome. IL-6, in my perspective, would not be the main suspect, so there are several other components in blood that can activate platelets. I think complement activation products are one of them. I would go for that, actually. And probably the mix of what's out there in the plasma is probably instructing platelet activation, if I may say so.
Do you measure von Willebrand subunit length in your unit in COVID patients?
Not routinely. So we have evidence that ADAM TS13 is lower in patients with COVID-19. And von Willebrand factor is up. But that's, I think that's also published. And it's not surprisingly, because most inflammatory infectious diseases show this profile. So in this respect, it's not really unique. What we did find, and that's done by people in the audience, Tom Reinders and Alex Schuurman, looked at comparison between regular community-acquired pneumonia and COVID-19 on the general ward, so not critically ill. And then what you see is that these non-severely COVID-19 patients show more evidence of endothelial cell disturbance, measured by biomarkers in plasma. So they measured like 10 biomarkers indicative of endothelial cell function activation. And that stood out. And that relates to your question in regards to von Willebrand factor.
As far as I know, there is no functional analysis on the function of the capillaries in these less severe patients, at least that I know of. That would be very interesting.
Yeah, absolutely.
Any other questions from the audience?
Tom, I have a question/comment. So we talk about platelet activation like it's one thing, but there are different ways that platelets get activated to do different things. So normally when we talk about platelet activation, we talk about platelets activating to aggregate, and we measure their aggregation. So, you know, as you would expect them to do when they form a primary clot at the site of an injury. That's an aggregatory response and adherent. What you've described is another type of response, which is a switch to a prothrombotic state, where they express tissue factor, they release microparticles, which also release tissue factor. That's not an aggregatory response, that's a prothrombotic response. And yet when we investigate antiplatelet agents, those are agents that will inhibit the aggregatory response, but have almost nothing to do with the prothrombotic response. So I just wondered what you thought about, you know, are we linking the right things, or are we even talking in the right way about platelets?
No, that's an excellent question. So I mentioned the title of my talk, which Jean-Louis came up with, is Platelet Activation, and that's a broad term, as you excellently pointed out. So people that are in the platelet field have these classic tests, like aggregation is probably the most classic test. But platelet activation incorporates many more responses, as you alluded to, and I try to provide some data about this. And it's right that these antiplatelet agonists, they interact with different receptors on platelets. And some of these receptors are involved all in aggregation, and others are less involved in aggregation, but in other responses. And the most common drugs that are out there were generated to prevent their aggregating capacity. You're absolutely right. So they were made for well, thromboembolic disease in general and the prevention thereof. So it's not totally excluded that other agonists that would interfere with other mechanisms would provide a benefit in patients with COVID-19. Now, having said that, I'm not sure whether these drugs that specifically target platelets are around. So there are drugs that can target, for example, tissue factor that has been studied in the past, but that has a major downside, because if you start to target tissue factor, you also compromise the coagulation system tremendously, and thereby introducing a high bleeding risk. So I don't see how this can be incorporated in a COVID therapy. So when you start to interfere with platelet and coagulation system, it's a tricky business, because they're there for a reason, obviously, and you only want to inhibit them to a certain extent. If you do too much, then you start to bleed.
Yeah, that's coagulation management all over. Any other questions?
Maybe to round it up, you have nicely shown the mechanisms underlying platelet activation and inflammation as acute effects. And I know this is really not an easy question to answer, but do you think that these mechanisms could also be responsible for a change in long-term cardiovascular risk?
So there's quite some literature about the long-term cardiovascular consequences of pneumonia in general. And COVID-19 literature starts to emerge, because obviously we're all only faced with this disease for slightly over a year. So the long-term consequences need to be fully established yet. So in community-acquired pneumonia, as you know, the first year after community-acquired pneumonia, there's an increased incidence of cardiovascular events, including myocardial infarction. And this has been associated with sustained systemic inflammation after community-acquired pneumonia, which is not very easy to dissect, because you have to rely on plasma measurements. And it's not that they are highly elevated, these inflammatory markers and coagulation markers, but there seems to be some association with sustained activation of inflammation, endothelial cells, coagulation activation, and long-term cardiovascular consequences. Having said that, this whole field of the long-term consequence of pneumonia, but also of sepsis, like cognitive dysfunction and also cardiovascular events, there's not so much data out there. So everybody focuses on the acute period, the patients are in the hospital, and it's more difficult, obviously, to follow patients in detail after they are discharged. And also the changes that likely occur more in the vasculature itself than you can pick up in the circulation. And obviously we don't have access to a large extent to the tissues. I think these are sustained consequence community-acquired pneumonia, but it's difficult to pinpoint what's exactly causing this.
Perfect. Thanks very much. So we're staying in the Netherlands, the heart of COVID coagulopathy research, with Professor Joffelmans from AMC.
Yes, Amsterdam rules this morning in particular. Other than that, I don't have any disclosures. Yeah, we have all these thromboses in COVID, and the question now is whether they can get infected. And this is a clinically relevant question because that would require prolonged antibiotic infusion. So we have pulmonary thrombosis, and this incidence is way higher in critically ill patients compared to COVID patients on the ward. And they occur in the lungs, but if you apply a screening approach, that meaning that you perform ultrasound in all of your critically ill patients, you will also find a very high incidence of thrombosis in the extremities of these patients, so in the systemic circulation, and the incidence of which may be even higher than the pulmonary thrombosis that is observed. The high incidence of these venous thromboembolic events in COVID definitely is related to disease severity. That is what this graph in particularly shows. But in contrast to the previous speaker, and I must disagree with him, I'm afraid, is that this is not specific or unique to COVID. Also, very high incidence of thrombosis have been found in severe viral pneumonia due to influenza. Although the numbers may be a little bit less than in COVID, they are still extremely high. So not only is this thrombosis occurring due to disease severity, there seems to be some specific interaction between the coagulation system and viruses, the exact interaction of which remains to be eluded. And the other thing is that indeed thrombosis in general, in a general ICU population, occur more frequently compared to patients on the ward, although of course it depends on what kind of patient population you are comparing. There is definitely a higher incidence of thrombosis in intensive care units. So thereby, this thrombosis is driven by disease severity, as already been alluded to by the previous speakers, as well as to the virus itself. So what about bloodstream infections? We find actually a very high incidence of bloodstream infections in critically ill patients with COVID. And here I'm showing you 4 observational studies lining incidences of these bloodstream infections in ICU. And of course, the incidence of this depends on your local flora and fauna and what kind of bacteria are around, as well as the infection prevention measures that you take in your ICU. But you can see that the incidence of bloodstream infections in all of these observational studies is quite high. And of importance, these bloodstream infections are not present when the COVID patient hits the emergency department. So these bloodstream infections, they develop over time. And also, the incidence of these bloodstream infections is higher if you compare these to non-COVID patients on ICU. So also there, a particularly high incidence. And this is another way of expressing it, that the risk of acquiring a bloodstream infection is higher in COVID if you compare that to non-COVID patients on ICU. And of note, corticosteroids haven't been noted as a risk factor for an increased risk in BSI, but tocilizumab has. So that's a risk factor for acquiring novel bloodstream infections on ICU. And the risk of this BSI is a factor of time. So the longer time you spend on the ICU, the higher the risk of acquiring a bloodstream infection. So the source of these bloodstream infections, or the type of microorganism that you find, is typically staphylococci and enterococci, as well as the enterobacterialis. But largely, in half of the patient, the microorganism remains, or the source of infection remains unknown in half of the patients. And this is an example of the electronic patient data file of a patient being in ICU for over 2 weeks. And you can note the frequent detection of positive blood cultures. And when we saw this, we were like, oh my God, what is happening? Why are we having so many positive blood cultures? perhaps this is related to the use of bodies in the ICU system in times of scarcity. We had a lot of nurses helping out, which were not maybe not used to handling of these of central lines. But then we figured maybe there's another explanation for this high incidence of positive blood cultures. As we know that COVID, apart from giving pulmonary endotheliolitis, it also causes GI symptoms such as diarrhea, etc. So there's also colitis going on, enterocolitis, which can compromise the gut barrier, causing translocation of bacteria into the bloodstream. And also another component to this could be that patients, although not often, some COVID patients do present with shock, which also decreases, of course, gut barrier. And if you add to this that it has been shown that after your COVID infection, you really have an immune paralysis with a lymphopenia, and also your lymphocytes, they don't perform well. They show all kinds of exhaustion markers. So in short, there seems to be an immune paralysis post-COVID. So if you add all these up, the hypothesis could be that it only takes a low amount of colony-forming units that perhaps can grow into these thrombi, which are present in the lungs and in the extremities. So we asked this question, is venous thromboembolic event, is that a risk factor for bloodstream infections or persistent bloodstream infections in COVID patients? And the implication of this would be the necessity of prolonged infusion of antibiotics. So we've performed an observational trial in the 3 main hospitals in Amsterdam during the first wave, and we've collected these data. We performed CT scanning, not regularly, not on admission, but on discretion of the physician, and the ultrasound for deep vein thrombosis was performed once a week. The definition of bloodstream infection, we took blood cultures upon clinical suspicion of infection, so just the normal clinical symptoms, and we termed it a bloodstream infection if one sample was positive in case of gram-negative or enterococci, or more than 2 samples in case it was a staphylococci. And in case all these hospitals had the clinical practice of replacing their central vein catheters when in case there was a positive blood culture. So the definition of persistent bloodstream infection was the identification of a microorganism in the blood culture, followed by at least 48 hours of appropriate antibiotic infusion, and then the identification, again, a positive blood culture with a microorganism with the same antibiogram, so the same susceptibility pattern. Recurrent BSI was defined as having a positive blood culture, and then again at least 48 hours of appropriate antibiotics, followed by a negative blood culture, followed by again a positive blood culture with the same resistant patterns as the initial microorganism. So this is what we found. I'm going to show you some tables and I'll walk you through it. We found that patients with bloodstream infections, they were sicker, as shown by an increase in SOFA score and longer time on the mechanical ventilator. And indeed, patients with the bloodstream infection more often had a venous thromboembolic event. Vice versa, if you then table the patients with VTE and compare the patients with VTE versus patients without a VTE, again, we find that these patients with a VTE are sicker compared to those without, as exemplified by, again, a higher SOFA score and a need for mechanical ventilation, but also higher C-reactive protein, etc. And also here we find that patients with thromboembolism, they more often have a bloodstream infection, and they more often have persistent bloodstream infections, and they more often had the diagnosis of recurrent bloodstream infection. And if you then try to model for this in a propensity-matched analysis, trying to rule out all the other confounders of having a bloodstream infection, it actually is the disease severity markers that are associated with the occurrence of bloodstream infection and no longer the venous thromboembolic events. So from this it follows that both thrombosis as well as bloodstream infection are are a consequence of inflammation, but the two are not linked together. Also, if you look at the literature, if you try to look for cases of, let's say there is infection that is undetected and undertreated, then this possibly would result in deep-seated infections such as endocarditis, prosthetic valve infection, arthritis, etc. in the longer term. And we should have had data with this by now with all of these huge COVID number of patients. But in fact, if you look for this in PubMed, you won't find any. So again, I guess this underlines that infected thrombosis is not really a typical event of COVID. Another question that may arise from these observations is whether or not you should change your central venous line on a regular basis. We normally don't do that because that hasn't been shown to be beneficial in ICU, so it's not part, at least not part of our clinical practice to change lines regularly. But in COVID patients, you may argue otherwise due to the high incidence of bloodstream infections as well as a high incidence of catheter-related bloodstream infections. I'm not aware of any data on the net benefit of the regular change of central venous catheters, but in our institution we have implemented this practice of changing of the lines every week. But this is non-data driven clinical practice. So with that, I would like to conclude. I've told you that both the incidence of thrombosis as well as bloodstream infections is high in COVID. They are both driven by disease severity, but they are not causally linked to each other. So thereby, having a thrombosis is not a risk factor for bloodstream infections. And I don't think that these results justify prolonged infusion of antibiotics. Thank you for your attention.
Thanks, Nicole. Any questions, thoughts from the audience? Nicole, is there any clue as to the origin from the type of bacteria that are being detected?
Yeah, so if you look at this type, as I told you, it's staphylococci, it's enterococci, it's also gram-negatives, and there's candidemia. So all of these microorganisms are known to arise from the gut. So in contrast to thinking that it's infection prevention, hygiene measures, I do think that there is translocation going on, which is also not specific for COVID. It happens all the time in ICU patients. But I think because of patients can have a gastroenteritis during their course of COVID, that it could well be that the cause is translocation. And this, I guess, also holds that it's difficult to find the origin in the majority of patients. So sometimes it's pneumonia or a central venous catheter, but oftentimes you don't find the source. So I think that speaks to me for gut translocation.
Question?
Daniel de Becker, Brussels. Nice presentation. Did you look at other places where thrombi may occur, meaning the axillary veins or jugular veins, others? Because sometimes we have seen quite a lot of these thrombi occurring after line replacement, and the question is, would these thrombi would be infected rather than DVT?
Yes. So we perform this ultrasound regularly, and we don't only screen for the legs, but also for the big veins, so where the catheters have been. And we oftentimes find thrombi on those places which have previously catheter has been inserted. So the question is chicken or the egg? That's your question, right? And for that I can't answer it. But my thinking would be that if you have bacteria circulating and you have catheters in place, these become, of course, contaminated as well. So I think that a policy of changing central venous catheters regularly is not a bad one in COVID.
And did you see any change when you upgraded your anticoagulation policy in the COVID patients? Did that change the incidence at all?
No, it didn't. We've looked at that. Another question, I guess, again, is whether corticosteroids influence the occurrence of thrombosis. Nobody has talked about this this morning. I'm not aware of any data. I would say that the incidence is lower. But then again, the question at hand in this talk, whether the thrombi were at risk for infection, I guess it holds. That is irrelevant of all the interventions that we give, I think. Yeah.
Perfect. Thank you, Nicole. So our next speaker has been released from her hotel room. Professor Hunt from London, who might be able to answer some of the questions we've just asked.
Well, hello. It is a real joy to be here in person rather than giving my lecture from my hotel room. So it's lovely to see you all. Okay, I have the rather odd task of talking about optimal anticoagulation in COVID-19. And I want to take you on a journey through where we have been with anticoagulation in COVID-19. I have no conflicts of interest other than I'm in rather a large number of living guidance groups for COVID. So I'm here to talk about anticoagulation, by which we are meaning that we want to give thromboprophylaxis to our COVID patients. And I need to remind you, we have two thrombotic processes going on in the COVID patients that we weren't really aware of at the start of the pandemic. So yes, we do have VTE. COVID-19 presents the perfect recipe. Very, very sticky blood, very high levels of coagulation factors as part of the acute phase response. We have endothelial cell activation. As COVID enters the endothelial cell, we know that markers of endothelial cell activation are very raised. And lastly, we are immobilizing the patients, so reducing flow, fulfilling all of the criteria of Virchow's triad. What we forgot about when COVID started was that we should have expected immunothrombosis. And by immunothrombosis, I mean microvascular thrombosis within the lung tissue at sites of high inflammation. And I'm going to be talking about it tomorrow. But immunothrombosis is not a new term. It was conceived in about 2013. And I think the intensivists needed to remind those doctors going into intensive care and who knew that actually this is a phenomenon of acute respiratory distress syndrome. So pre the pandemic, we have clear evidence that thromboprophylaxis is effective in reducing rates of venous thromboembolism in hospitalized patients. This is the data from randomized controlled trials of thromboprophylaxis versus placebo at the turn of the century. About 20,000 patients went into trials. This data summarizes and shows that the relative risk reduction is about 50% in the ward patients. And then we have multiple randomized controlled trials looking at patients in intensive care. They too show we have a relative risk reduction with standard thromboprophylaxis of about 50% in the critically ill patients. If you ask that question, is low molecular weight heparin better than unfractionated heparin? The answer is yes, it is. And certainly in Europe, we widely use low molecular weight heparin in preference to unfractionated heparin. So when the pandemic started, we were all desperate for information about the use of anticoagulation in the critically ill patients. And this is a very early paper that came out, typical of the time, March 2020. It came from Wuhan, and it's fairly crude, and basically said, if you give heparin to patients in critical care who have COVID-19 pneumonia, you are reducing their mortality. Now, I don't know if you remember all those early papers, but their content was poor. Data was being published that wasn't peer-reviewed, and this paper didn't say what type of heparin Why weren't all the patients in critical care receiving thromboprophylaxis? Clearly, in China, it's not given widely in critically ill patients. What dose? What was the indication? Nevertheless, we had this data. And when we started out, we were all very aware that our patients had very high rates of clots in their lungs, on CTPA, and also DVT. And one of the responses from the doctors looking after these patients was to increase the amount of anticoagulation given to these patients, because it appeared they were having much higher rates of venous thromboembolism than any other patients previously in critical care. So guidance came out, and there was quite a divergence in the guidance. So some of the guidance, such as this one, International Society of Thrombosis and Hemostasis, it came out April, May last year, said maybe we should be using intermediate dose thromboprophylaxis in critically ill patients. And we were aware that some units were using full dose anticoagulation as thromboprophylaxis. Others, such as the World Health Organization, said there is no evidence to support using higher dose anticoagulation, so we suggest you use standard thromboprophylaxis as you would normally. And we have really waited until this week, in this week's New England Journal of Medicine, or maybe it was last week, to finally get the results of randomized controls looking at the question of what dose of anticoagulation is best for our patients. So this is an extraordinary undertaking. These are 3 platforms. This is the REMAP-CAP, Active-4A, and the ATTACK investigations, who were all really looking at much the same thing, full dose anticoagulation versus standard of care in a randomized way in critically ill patients, and also those with moderate disease, the ward patients receiving supplementary oxygen. And what do we find? I'm going to walk you through these results. I think that they're quite difficult. They use Bayesian analysis, which is not something that we are used to as a community. But essentially, when we look at the critically ill patients, using an endpoint, and they use an ordinal scale saying death, and looking at the number of organ support-free days at day 21 after admission. So we're looking at clinical outcome, not rates of thrombosis. We're seeing no difference between those who had full dose anticoagulation versus the standard of care. And standard of care, for the reasons I have just explained to you, in some units was intermediate dose thromboprophylaxis, and others was standard thromboprophylaxis. So no difference in outcome, but when we look at the rates of major bleeding, we've got 3.1% with therapeutic anticoagulation, full dose anticoagulation, and 2.4% with the local standard of care. So quite a lot of patients were screened to go into the study, and ended up with about 1,000 patients in the trial. I'm sorry this is so small. So this is summarizing the demographics of these patients. As you expect, we've got 70% men, and as we go down, we have an average BMI of 30, so typical COVID patient, and just walking through, 80% of them received steroids as well, and a few received antiplatelet agents. Now, for this study, 74% of the patients came from UK intensive care units, so it was mainly REMAP-CAP that had put these patients in this study. So here we have the primary and secondary outcomes. You can see there is very little difference, however you look at it, in clinical outcome, rates of thrombosis and thrombotic death between the two groups. And then we have this other way of looking at it, looking at those who had died in red and those who had organ support-free days, the most in the dark blue. Again, very little difference between the two groups. So we have to conclude that therapeutic anticoagulation as thromboprophylaxis has no clinical benefit in patients in intensive care. But this study also involved those who had moderate COVID, so supplementary oxygen, but not high flow or CPAP or invasive mechanical ventilation. And in that group, we have a slightly different result, in that there appears to be some evidence in benefit in that anticoagulation at a full dose increased organ support-free days compared to the standard of care. And in this group, we have a lower background major bleed rate of 0.9%, going up to 1.9%, which many would find acceptable in patients on the ward. Again, we've got this different way of displaying the results. Some people find it useful, I'm sure I do. And then if we look at the demographics, we've got the same groups. So we have got mainly males. We have got a raised BMI, the average is about 29.5. Lower groups who are getting steroids, so about 60% were getting steroids. And I think the thing to say about this study is that most of the patients were recruited in North America. So this was the active 4 and the attack arms of these platforms that were recruiting patients into this group. So slightly different group and different practice in the countries. The other thing that was looked at in these studies, and if you take your mind back to early COVID, everyone was commenting on the height of the D-dimers. We knew that D-dimers, if they were very high, had a poor prognostic outcome. So we looked in these studies at the different categories of D-dimers, very high and the low, and separated out the results according to D-dimer level. And you'll see that there is no difference in outcome with the height of D-dimer. And I would argue that actually the D-dimer represents the degree of disease in the lungs, and it's the lungs themselves producing urokinase which is causing this high D-dimer. Here we have got the secondary outcomes. So we've got some evidence that we have got reduction in thrombotic events. We don't have a positive result just looking at death. It's the composite outcome, so death and thrombosis, that is significantly reduced. So the summary of these trials is essentially saying we should be considering therapeutic anticoagulation in those who are moderately ill, but we should be using standard thromboprophylaxis in those who are in intensive care. And the recognition that we have got variation between intermediate dose and standard thromboprophylaxis in the standard of care. So we also have another trial looking at therapeutic anticoagulation, which is the action trial that was published about a month ago in The Lancet. This is a Brazilian trial mainly, and in this trial they used full-dose rivaroxaban mainly. A few patients got low molecular weight heparin versus standard thromboprophylaxis. We have no difference in clinical outcome, but we have a significantly higher rate of bleeding. So we're talking about 8% of the patients getting major bleeding compared with 2% in standard thromboprophylaxis. And this group included some moderate and some severe. And then lastly, we have the inspiration trials. This is about 500 patients who were randomized to intermediate dose versus standard of care, so that's just weight-adjusted low molecular weight heparin. And this study suggests there is no difference in clinical outcome between these groups, but again, we have a higher bleed rate in those who got intermediate dose. So they have a bleed rate of 2.5% versus a background rate of 1.2%. So this suggests that in critically ill patients, we should just be using standard thromboprophylaxis, not intermediate dose. And one of the previous speakers has already talked about the aspirin use in the recovery trial. Just to remind you, we have considered aspirin to be a thromboprophylactic agent, but no benefit in the COVID ward patients. So just to stop here, we're saying that we should be using standard thromboprophylaxis in one group, but a therapeutic dose in the moderate group. The rates of reduction of thrombosis aren't that high, and I need to remind you, rivaroxaban had very little effect. Could it be that heparin is working as an anti-inflammatory or an antiviral agent rather than as an antithrombotic agent? Just leave you with that. The next question is, these patients have been very sick. Many have spent extended time on critical care. Should they be receiving post-discharge thromboprophylaxis, known as extended thromboprophylaxis? Prior to the pandemic, this is the available evidence. Trials using low molecular weight heparin post-discharge have shown a slight reduction in VTE, but an unacceptable increase in bleed rate. And looking at the direct oral anticoagulants, betrixaban and rivaroxaban have a license in North America to be used for extended thromboprophylaxis because they do slightly reduce the VTE risk without increasing the bleed risk. This data got taken to the European Medicines Agency and they threw it out. They said the cost efficacy is not good here because we are only slightly reducing VTE rate and these drugs are costly. So what data have we got? Well, we've only got observational data. A hospital that I'm linked with, King's College Hospital, has looked at the rates of VTE in the COVID patients post-discharge and compared them with the rates of VTE in patients who had discharged the previous year and found no particular difference. They do not use post-discharge thromboprophylaxis. You can see the rates are very low. They're about 1.5%. But we have this big data, again retrospective from Northwell, New York. So they looked at over 8,000 patients discharged post-COVID-19. They gave 30 days thromboprophylaxis to those they considered high risk. So that's the elderly, raised D-dimers. Of course, everybody has raised D-dimers with COVID, and they used something called the improved score. Their post-discharge VTE rate was 1.5%, and if they got anticoagulation, then they reduce the rate of VTE by 50%. That 50% rule that we know with standard thromboprophylaxis. So the jury's really out here because we've got low rates of VTE post-discharge, but some evidence that there's benefit of giving extended thromboprophylaxis, and we're waiting for people to complete randomized controlled trials in this area and report. So thromboprophylaxis has got complicated. This is from my institution. This is the one iteration before last, because you might notice it says use intermediate dose thromboprophylaxis in critical care. For the ward patients, we recommend full dose anticoagulation. Everything I said has been summarized in an editorial in the British Medical Journal. And we're left now with some questions. So we've come a long way with thrombosis and COVID. I think the data is very clear that the rates of VTE are higher than any other illness. We have this issue of immunothrombosis, which I define and my unit defines as segmental and subsegmental changes on CTPA. Not everybody would agree. We need to find some way of distinguishing between PE and immunothrombosis. And then on thromboprophylaxis, we've got some clarity about when to use standard thromboprophylaxis. Should we be using intermittent pneumatic compression? Should we give extended thromboprophylaxis? And the question that Nicole raised earlier, we have the issue of immunothrombosis. If we give anticoagulation, are we reducing the rates of immunothrombosis? I suspect not. I suspect it's the use of the anti-inflammatory agents that is doing that. So the whole thrombosis community has had this extraordinary journey with VTE. Outside of COVID, we have got increased rates of VTE coming to us because many patients have taken lockdown as a chance to sit still at home and eat burgers and donuts, and so they increase their weight, and we have increased numbers of VTE from those who have got the COVID tire and immobile at home. Now we have the vaccine-associated immune thrombocytopenia and thrombosis to deal with, and some of us are now tackling the post-COVID problem, long COVID, and looking at what is happening to coagulation in these patients. Thank you very much.
Thanks, Beverly. Nicole?
Thanks, Beverly. Wonderful talk. Wonderful to see you alive again. A question to you about the post-discharge rate of thromboembolisms. I think these were for all hospitalized patients, right? Not for critically ill. And if so, do you suspect that the post-discharge rate would be higher for critically ill patients? So should there be an exception that possibly they would benefit from extended duration of thromboprophylaxis?
Okay. When we talk about extended thromboprophylaxis, we're usually talking about patients who've had a 6-day to 14-day stay in hospital. That's the average length of stay in the initial studies. I know that for some of the COVID-19 patients in critical care, they are there for 21 plus days. So you could argue they are already receiving extended thromboprophylaxis. I think if they have become debilitated and poorly mobile, there is a place for them in particular to receive extended thromboprophylaxis. And certainly in our institution, we are giving it to those who are poorly mobile on discharge. Thanks for your question, Nicole.
Can I have another one?
Yeah, go on.
Go on.
Yeah. So you are advising against intermediate dosing prophylaxis in ICU based on one study, really, which is if you look at the case mix of the patients in that study, only about, if I recall correctly, about 10 to 15% required mechanical ventilation, so they weren't that ill. So I'm feeling that your recommendation is quite strong, and I still have this worry in the more severely ill, the really critically ill patients, whether, you know, only standard doses is enough. I mean, we haven't adapted our clinical practice based on this one study.
So you're quite right, there's uncertainty here because it's a fairly small study and it's got fewer critical care patients than one would like. REMAP-CAP now has an arm where we are comparing standard thromboprophylaxis with intermediate dose. So there will be more data in that area. But I think for me, I would prefer our patients to have standard thromboprophylaxis until we get data to show that intermediate dose might be a little bit more beneficial.
I have one other question. You mentioned that AstraZeneca and Johnson & Johnson causes thrombosis as well, for sure a lower rate. Why is it like this? Why vaccines cause thrombosis as well?
Okay, you're asking me about VIT, vaccine-induced immune thrombocytopenia and thrombosis. In those rare cases that are about 1 in 50,000 to 100,000 after the J&J and the AstraZeneca vaccine, the patients have developed an antibody to platelet factor 4, and it's a sister disease to heparin-induced thrombocytopenia and thrombosis. However, if you look at the rates of thrombosis in people who've been vaccinated, they are higher than the background rate, and there is data to show that if you receive a vaccine, you have an inflammatory response in the week after vaccination, and we are seeing a slightly higher rate of thrombosis, I suspect, because of that.
It's a subject to our next talk, I think. Beverly, I have an existential question for you.
Oh, no.
If the results of the trial are true, and we know that in standard pulmonary embolism, therapeutic anticoagulation is effective in improving outcomes, and if we know that the incidence of pulmonary embolism is so high in COVID that there should be an effect, then does that mean automatically that actually the presence or absence of a pulmonary embolism is irrelevant to the clinical course of a COVID-19 patient?
That's packed. We give anticoagulation in patients who've had a thrombotic event to prevent them having any more clot extension. So it's really not treatment, is it? It's secondary prevention. Does pulmonary embolism make a difference to the mortality in COVID-19 patients? And JLV talked about this on the first day. And I mean, some patients with COVID do die of pulmonary embolism. Does that answer your question?
I don't know. I mean, it seems that if there's a 40% prevalence of pulmonary embolism, some when they hit the ICU.
Okay, so this is where Nicole and I would differ, because what they saw and what that paper saw was 40% of the patients had changes on CTPA. And the problem is the radiologist reports all of those areas of non-flow as pulmonary emboli. But the issue is that many of the patients have immunothrombosis, and immunothrombosis is microvascular thrombosis. You will get a little bit of damming back of blood, and so segmental and subsegmental changes would probably represent immunothrombosis. So in those patients that just have segmental and subsegmental changes, if you take them out of that 40%, you're down to about a 5% rate of PE.
So they're two different things that we're trying to treat with the same thing, is what you're saying.
Exactly.
So Can I have a question also? Thank you very much for the lesson. But some of our patients have some extremity problems. For example, in one leg or in one finger, there is a perfusion defect, but we couldn't see it with the Doppler, but maybe this is also thrombosis. So in that selected patient group, do we have to use therapeutic heparin? I mean, we use, but are we doing wrong?
You're asking me, I think, should we give therapeutic anticoagulation to anyone who's got changes on CTPA?
Or in the extremities, in the leg or in the extremities. Sometimes we found some perfusion, not perfusion, but...
Are you talking about VQ scanning here?
No, it's distal extremity ischemia.
Okay. So non-flow does not necessarily mean thrombosis. And it's a difficult question to answer. If you have doubt, then it's like you suspect someone has a VTE, you would give therapeutic anticoagulation. But we need to know more about what the non-flow means, I think.
Okay. Thank you.
Thanks, Bethany.
Thank you for this very interesting discussion. So to sum up the session, I am very happy to welcome Professor Daniel de Backer from Brussels, and he will talk to us about vaccine-associated complications.
So thank you. Good morning. It's of course much more rare than all the other features we will talk about, but it's a bit more complicated when you are facing families of these patients coming and sometimes dying in our ICUs after having received the vaccination. So to begin with, there is absolutely no doubt that these vaccines, all of these, are quite excellent. They provide excellent protection, and they are usually, as in the initial trials, associated with minor adverse reactions, flu-like reactions that we all encountered when we were vaccinated ourselves. However, there could be some other features, and anaphylactic reactions were also reported, but also these were quite rare and not very frequent in most cases. And when we look in the real-life setting, like with this kind of papers, we can indeed confirm the excellent coverage and protection provided by the vaccine, and at least with the fatality rate, we can see that the risk-benefit is really in favor of receiving the vaccine. Having said that, this does not mean that with some specific individuals we will not encounter some very dangerous adverse events. And we have to recognize these and to try to treat these as best as possible. And among these events, we have, of course, clotting-related events like the thrombotic events, but also some other events that we also need to be aware of, including the capillary leak syndrome and the myocarditis. Regarding the thrombotic events, we have two types of events. The first one are the classic thrombotic events without thrombocytopenia usually, and often in patients with thrombotic events in their previous medical history. On the other hand, we have a more difficult syndrome, which is a vaccine-induced immune thrombocytopenia and thrombosis, VITT as the acronym. And if we look at the first one, the thrombotic events, the EMA look at it at the incidence of thrombosis and without thrombocytosis. And for this, there was no significant increase in the incidence of this event. And so even though indeed we can admit that in some cases the vaccine played a role by its inflammatory reaction in triggering events in patients predisposed to develop thrombosis, in most cases, it is not leading to increased incidence and should not then be a major trouble for most of the patients. However, shortly after this report in March 2021, we had in April this year, these reports in a few weeks that indeed we have some specific syndrome with thrombosis and thrombocytopenia that occurs after vaccination. And in most of the cases, it was after some specific vaccination, mostly the AstraZeneca vaccine, but also the Janssen vaccine was also submitted to this. So when we look at the data, these are quite the first one published, of course, initially as a preprint, showing that in a very short series of patients, there were some very specific features. All had cerebral vein thrombosis. All these patients also had very severe drop in platelet count, very high levels, of course, of D-dimers, and these investigators were going one step forward and were trying to look at anti-PF4 antibodies. And they realized that indeed by ELISA, there was indeed an expression of this anti-PF4 antibody in this condition. They also looked at blood smear and disclosed that schizocytes are present in these blood smears. So indeed, a very classical feature of prothrombotic thrombocytopenia, and associated here with the expression of some specific antibodies against PF4. So these were the first report, and all the subsequent were aligned and going in the same direction, showing indeed the relevance of these antibodies, with indeed when heparin, whatever the type, was added here, an increased activation of the platelets in these conditions, and that indeed was again demonstrated by several ways in the different trials. So it was, of course, very relevant because the first intuitive reaction will be to treat this patient with classical heparin, and of course, because of the presence of this antibody, the HIT-like antibody, we indeed have to change our therapy. Because of the immune concept also, investigators proposed to use high-dose immunoglobulins, to use also anticoagulants other than heparin, indeed direct 10A inhibitors mostly in these conditions, and to prevent, if possible, platelet transfusions. And this was also based on the presence of cases in which indeed they experimented the different procedures, and mostly show after the introduction of the immunoglobulins a rapid increase in the platelet counts in most of the patients. So the actual proposition when we face a patient with thrombosis is indeed first, of course, to discuss with the local hematologist, but also to rapidly look at the D-dimers, because indeed the D-dimers are often very elevated in most of these patients. And then also to do some sampling for the anti-PF4 in these patients. While waiting the results, of course, treatment should be to avoid platelet transfusion, to avoid heparin, and to use other therapies, including immunoglobulins in these patients. And then, of course, when the results are received, if it is confirmed, to continue the therapy as suggested, otherwise to use classical heparin if needed. More recently, and the previous speaker was one of the key authors of this paper, the UK investigators looked at the data from Public Health England, so all the reported data on this thrombosis that may occur, and they use, of course, a very nice way to determine which of these adverse events were likely related to VITT or which one were unlikely related to VIT. And so the criteria were the 5 criteria with the onset of symptoms between 5 to 30 days of anti-COVID vaccination, the presence of thrombosis, the thrombocytopenia, the high D-dimer levels, and the positive anti-PF4 antibodies on ELISA. And they were, of course, decreasing the assessment by having one of the factors missing or more of the factors missing. Among the a little bit more than 200 patients they observed, what was quite interesting is to realize that first, cerebral vein thrombosis or intracranial hemorrhage were really the leading factors, followed, of course, by DVT and pulmonary arteries embolism, but also, very important, especially for prognosis, the portal vein and splanchnic vein thrombosis, which were also very important in some of these patients. When we look at the age of these patients were quite young. And it's important to realize, because indeed, vaccination always begins with the elderly and then come to the young people. And so indeed, these were mostly young people who experienced this. A little bit a higher rate of females here, as you can also see here. And as expected, the distance from vaccination was on the average 14 days here. You can see the platelet count very low in most cases, and all the other factors were, of the coagulation were more or less normal, except, of course, the dimers who were markedly elevated in these patients. When we looked at the timing from vaccination, we realized that indeed the 10 to 20 days were really the most important period where these cases were found. And also, when we look at the age, there was a sharp increase in the incidence around 50 years. After 50 years, the incidence markedly decreased in these conditions. So, if we look at the other features, like the platelet counts, we can see that in most of the patients, it was around 40,000, but it was very low in some other patients. Fibrinogen values range from close to normal, elevated, and also lower, but was so not major alterations there. But D-dimers, on the other hand, were very high in many of these patients. Looking at the factors associated with poor outcome, it is interesting to realize that fortunately only 1/5 of the patients died. And on the other hand, that when we look at the factors associated with unfortunate outcome, the cerebral venous thrombosis was one of the factors. The intracranial hemorrhage, of course, was also one of these. The low platelet count and platelet count below 30,000 was associated with this. And also the elevated D-dimers could play a role there, but no major difference between the two here. When computing the incidence based on the data available on the number of vaccinations, they also computed that for the patients above 50 years old, it was 1 every 100,000 patients, but below 50 years old, it was 1 every 50,000. And that's why perhaps some European countries mostly changed their ways to handle the vaccine, the Astra vaccine at least, and reserve this for older patients only and not for younger patients, due to this aspect. If we look at the incidence, is it really higher than what we expect? And this is an interesting paper also from a consortium of people looking at cerebral vein thrombosis. And they look at the incidence of anti-PF4 antibodies in these and thrombocytopenia in these patients. And among the 1,000 patients, they have only 80 patients with thrombocytopenia, so it's already quite rare. But you can see that it was explained by many other factors. It was only hit in these conditions in only one of these patients. So a very, very, very rare occurrence. And this makes indeed the VIT very specific. And so the EMEA indeed makes this event as something very important. The rates they suggest here are higher than the UK data, but the UK data were not published at the time they were publishing this advice, that indeed thrombosis with thrombocytopenia is a concern that can be observed with the Astra vaccine. What could be the, and the Janssen's also, what could be the mechanism? Well, it is induced exclusively by the adenovirus-based vaccines. And so it seems to be a role of the non-replicating adenovirus in this condition. And the difference between the mechanic of the thrombocytopenia that is sometimes reported during COVID-19 is that, of course, the virus itself in these conditions encounters the platelets, induce the production of PF4 that can be recognized by B cells, leading at that time to the production of the anti-PF4 antibodies that then led with the thrombotic events later on. For VIT, it's a little bit different because indeed the direct activation of platelets by a non-replicating adenovirus is unlikely because the vaccine particles are not supposed to reach the bloodstream after injection. So other mechanisms should be implicated. And it has been suggested that the vaccine adenoviruses would infect the endothelial cells, inducing the local production of the spike protein, which then will be expressed at the surface of the endothelial cells and recognized by the platelets, leading then to the expression of the PF4 antibodies. Then rapidly, the other complications, and the systemic capillary leak is one of these. Just one case we unfortunately lived in our unit. It was a young lady with no major history, myalgia and fever in the following days after the vaccine. And then she presented in the ED 48 hours later because she felt lipotemic and developed severe hypertension. Initial echography showed preserved ejection fraction and severe hypovolemia. Fluid steroids were initiated at that time, and rapidly we initiated also epinephrine due to the decrease in the blood pressure in these conditions. At the ICU admission, it was much more severe, with a huge increase in the hematocrit, a huge drop in the albumin levels, indicating the capillary leak. The patient was edematous at that time also, but still, of course, very hypertensive and very hypovolemic. Severe respiratory failure occurred, and the echography disclosed myocardial edema, severe myocardial depression of the both ventricle, ejection fraction lower than 10%, cardiologic shock at that time, but still hypovolemia. So we continued by inserting the VAV ECMO at that time. We have to follow by some try to attempt to eliminate the mediators, but unfortunately nothing evolved in a good condition. The patient had initial transient improvement, but rapidly deteriorated and finally died 80 hours after vaccination. So this is really something dramatic. And indeed, it is after this case that indeed these may have changed slightly the recommendation, mentioning that indeed it may occur in these conditions, and also that it should not be given in people with history of capillary leak. And here, the US experience, not the Astra, sorry, but the Janssen's, Moderna and Pfizer, also 3 cases here, 1 collapse also here. And since then, there have been, on the EMEA, 22 cases reported in Europe, mostly Astra, but also Janssen's, 3 cases in the US, Janssen's, Moderna, and Pfizer's, and only, if we can say, 2 cases after COVID. So the incidence after vaccine is much higher than it can be in other conditions. And so it is very difficult to identify who may really be at risk there. And this is really something very difficult when you have to face families later on in our ICUs. To end with the myocarditis, which is a totally different aspect. And interestingly, what has been shown is that compared to the expected incidence of myocarditis, it occurs much more in young people, and especially in young males, that indeed these patients have an increased incidence of myocarditis compared to what is expected to their age rate and the representatives there. And so it mostly occurred 2 to 10 days after the second dose, and the second dose of two specific vaccines, the mRNA vaccines, and it is young males more than females, and it is often very mild, but it can be also catastrophic evolution described in some conditions. For the therapies, we are a little bit more limited. Mechanism is not yet decided, and so we use colchicine, steroids, and non-steroids agents here also in addition. But again, even in this population, we have to remember that even though there are a few myocarditis cases that can be expected here, the benefit is still very important. Even in this young age, there is a prevention of hospitalization, which is indeed, again, effective there with the vaccination. So COVID vaccines are safe and effective globally. So the problem is that we have, in some cases, thrombotic events that may occur, non-specific to the vaccine itself, triggered by the inflammatory response, and these may occur as well in many other conditions. In very rare conditions, 1 to 100,000, we have, with the non-replicating vaccines, the VIT that can occur, and this immune reaction requires prompt recognition and specific therapies, avoidance and heparin, and administration, steroids, and NIVIC. And capillary leak syndromes is triggered by all vaccines, but it's extremely rare and perhaps even underreported. It is a catastrophic event that occurs in susceptible individuals, difficult to identify before. And myocarditis occurred after the second injection of the mRNA COVID vaccines. It is usually of limited clinical consequences. And with this, I thank you for your attention.
Thank you very much, Professor De Backer, for this good overview. We have just time for one question from the audience, please.
Thank you. Yeah, my background is I work in the medical device industry, and I know personally one friend of mine who had a heart attack and is now brain damage, 1 stroke, but is fine, and 1 person died. I don't know anyone of COVID-19 who died in my personal subjective life. My question is now, with the vaccine, now the 3rd artificial infection will be given. So the 3rd booster vaccine will be given. So what do you expect, what will happen if the people get the 3rd vaccination? Regarding to your research, what is your personal view? Thank you.
So first, it is obvious that the risk associated with the vaccines are much lower than the risk associated with the COVID. And all in the room here, we know much more patients who died in our ICUs, including young people, 18, 20 years old, who died after some weeks of ECMO in our departments. So vaccines are effective, prevent death, and we have population data showing this. Admittedly, we have now the issue of knowing who can benefit from a 3rd dose. This is something totally different. What is obvious is that the people who had already some severe reactions as those described here will probably not be submitted to further vaccination, because for most of the individuals, these are immune-induced aspects, and when you have something which is immune-induced, it's not good to replicate the insult in these conditions.
Thank you. Just for maybe to close, one question.